far as I am aware, tutoring is in effect today, 10:30, and again at 4 with the Zoom. Everything else okay with everyone else's clinicals? Any issues or concerns with clinicals? No? We're good? Everybody's just staring at me. I want to make sure everybody's good. I know, it's Monday, I know. All right, Seagate, what's happening at Seagate?
Professor Graham wanted to switch the time.
And the reason for that is?
Whenever we come up, they're already done getting all the meds, done everything. So when we come in, normally 8:30, and as far as we can tell, I think
6 to 2 is their shift?
Yeah. We do everything like the medication, all the changing of
they tell us like, why
early.
are you coming up now? Like, we're done everything, and then we're like, I don't know what to tell you. Like, then we
They
do the
assign
assessment,
us to
like,
the
that's
floors
it.
that they want us to go on. So by the time we come at 8, then we wait for the person that's supposed to tell us what floor we're supposed to go on. They're coming at probably 9.
Okay, so then we have to switch it up. I'll speak to Professor Barry.
Picked 2 floors for us to do. So last week we did that, and this is the time to do, so she wasn't sure what to do. Like, she's gonna do that, but, like, again, we're coming.
How many floors are in the facility?
7.
There are, I think, 3 to 7 are the ones that are with the residents.
Okay.
It's not that we wanna switch it up, it's Professor Ben, she wanna see if we can go earlier.
So you don't miss things?
Right.
No, I
Exactly, yeah,
understand.
yeah.
Is that a hardship for anybody?
I mean, we'll make it work if we have to.
Okay, all right, and what about, Carmel, how's that going? Yeah, everything is okay so far? Okie dokie, all right, so we're a little bit behind, so let's get started.
How you doing? Did you learn the medication? Did you learn medication? No.
I'm so tired. Jesus, it's so tired. Everybody.
Yeah? No. 5 of them. But I do not. It's one by one, and then if you will ask me, it's like a mess in my head. Yeah.
I wanna ask the we're using all of them.
Tell me please. Listen. Right?
And we bring up to the training, they are millions.
Lauren, did you find it?
And the dogs.
هذا سرطان اللي رشمت له رأيت سرطان.
All right, okay, that's good. All right, everybody, let's get started. Okay, where did I leave off? Here, right?
Yeah.
Okay,
Tarila.
I thought I did, I wanted to make
Show
sure.
me.
I'll show you.
Okay, so, let's continue on. We were talking about the beginning of our medications. Let me see where we were, just to give you a tiny little recap. Okay, we talked about some terms and the types of preparations. Okay, so we were continuing on with that. Okay, so everybody knows what a capsule is, right? You've all taken capsules before. Okay, you don't have to memorize this. This is just, information for you. An elixir, we talked about that, that's a medication in a liquid form, and it's got a little bit of sweeteners and flavor in it. Enteric coated, you will see a lot of. Can anybody think of a medicine?
Aspirin.
Very good, absolutely. That's enteric coated and it bypasses the stomach and it starts digesting after that to avoid folks with sensitive stomachs so they don't get irritated. Anything with ER, CR, CRT, anything with initials after the name is usually some type of controlled, extended, or a sustained release. So in other words, in a nutshell, it is a medication that over a period of time will be released into the body. So little by little, okay? And drug companies make medications like this because, does anybody know?
It's addictive. It's addictive.
You know, they don't make narcotics that are extended release except in patches.
Because, well, I think because they don't want to get, for example, if I'm getting a medication that works on GI tract, I they wanted to get released on like the small intestine so it doesn't irritate the stomach, for example.
Okay, that's good.
Or maybe it's not gonna be as effective if it's breaks down in
Well,
the mouth.
think about what would happen if we took a sustained or timed release tablet, capsule, whatever it is, and we crushed it because our patient had a peg
It's
tooth.
not gonna work.
Well, it will work,
Too
Too
fast,
fast.
but what will happen, the patient will get like a bolus,
Yeah.
like a big plop, right, of medication into their system, which is not the way the medication is designed to do. So think about, even for us, can anybody think of a extended release medication that we might take?
Aspirin also, it's not supposed to be crushed, no?
Depends on the aspirin, but think about any over-the-counter. Anybody see any over-the-counter
Yeah, they
medication?
have like over-the-counter, like Advil, Tylenol, I know.
Yeah, Advil and Tylenol, they also make it in an extended or timed release to last longer, okay, and give a better effect of the medication. Okay, lotion, we all know what lotion is. We can put medication in a lotion form. Think of a medication that maybe would be good for somebody that has a common case of poison ivy. So you can buy that over the counter, calamine lotion. Or if you remember you yourself or your kids ever had chicken pox, we used to put calamine lotion on the little pustules as they were healing. Used to be pink, now they make it in a clear form. Okay. Lozenges, we all know that, right? We're coming into flu season, so think of your cough drops, okay? They make medications in lozenge form that can dissolve in the mouth. Okay. Ointments is usually something that is applied externally. It's a semi-solid preparation. So what's an example of an ointment? Yep, Mastotracin, absolutely. And a pill, you know what a pill is. It's your standard PO medication, and it comes in various shapes. That's just according to what the drug company designs it. Okay, powder. Powder is, a medication can come in a powder. Think of, I'm just giving you an example that you can maybe relate to over the counter. Metamucil, right? They have commercials for that. You dissolve it in liquid. It is a powder form. Other medications come in powder form. Antifungals over the counter can come in a powder form. A solution is a medication that's dissolved in some type of what? Liquid. It's a solution, right? Suppository. Why do you think medication in the form of a suppository might be beneficial for the patient?
If they're vomiting?
Yes, excellent. If you can't give them something PO because they're vomiting, you have to give it another route, right? So a suppository rectally could be a route, right? Why else might you give somebody a medication in a suppository form?
There's more blood capillaries, so it's easily absorbed.
Well, definitely it's absorbed, and think about the
And then-
warmth. It's internal, right? So it's gonna dissolve faster, okay? So they give all sorts of medications in a suppository form, and you will do that as well, okay? Suspension. A suspension is an undissolved particle, either, prepared that way or crushed. And it's in a liquid medium, and it needs to be shaked or mixed before you give it. So what could be an example of that?
Antibiotic.
Could be an antibiotic, right? Sometimes, remember, the undissolved particles might settle down. If they weigh more, they're gonna settle down to the bottom, and you need to shake it. There's also a medication that sometimes we crush to give to folks that can't swallow, so we give it via NG or PEG. It's called Carafate. We don't give it as often, but it's been around for a long time. It's a big white pill, but with this particular medication, when you crush it and you mix it in the water before you give it, if you don't give it right away, the particles are so heavy they settle out very quickly, so you can tell the difference. So what happens if you're giving something that's crushed to a patient that has an NG tube or a PEG tube? What do you think could happen?
Aspiration?
No, we're giving it because they can't swallow, right?
Yeah.
So any pill, any capsule, anything we have to open, anything we have to mix, anything we have to crush, we need to be mindful that because these particles can settle quickly, you can get a clog in either the NG tube or the PEG tube. So it actually stops up, like think about a drain or a pipe, it just stops up because it solidifies within the tube. It's very, very difficult to, get that unclogged. So you will see, hopefully, if the nurses are giving meds, if you're giving meds, if you have somebody that needs a medication with a PEG tube or an NG tube, first find out if that medication comes in a liquid form or some type of suspension that you can just pour, okay? That would make it a lot easier and it would not actually clog. What if you can't get it in a liquid form and you have to crush it? What do you think you should do? Well, you do one at a time, so hopefully you'll see the nurses crush one at a time. They're not taking like 2 or 3 pills and, beating it to death with the pill crusher, because that's too much. It's too much sediment there that you're gonna have to mix, and it increases the chance of clotting. So one at a time. Please remember that, because if you do one at a time, it might take you a little bit longer to administer the medication, but you won't have any clogs, okay? So that's pretty important. And then, of course, a syrup, which is also a liquid medication in a liquid form. But what's the difference between a syrup and maybe just your standard liquid medication? Think of syrup that you put on pancakes.
Sugar?
And other one have alcohol.
Has some sugar, yes, they all have a little bit of alcohol, but what's different with a syrup? It's thicker, exactly, right?
Yeah.
It's thicker. So with medication that comes in a syrup form, you might have to dilute it a little bit, okay? Because otherwise it may take forever to go down either the NG tube or into the PEG tube, okay? And you don't want to push it, okay? You want to let it go by gravity. Tablets, we talked about. Transdermal patch, okay? This is actually a small adhesive patch that you put on your patient's arms. You can put them on the anterior part of their chest. We rotate the sites like we do with anything else. And in this patch has medication that is absorbed through the skin, okay, through the skin. Once it goes through the skin, eventually it makes its way into the circulation. So, we talked about, before your peer said something about addictive. There is a patch that you can put on a patient if it's ordered for pain.
Okay, is it
Narcotic.
Fentanyl?
Fentanyl is one of them. And the thing is, with any kind of a patch, whether it's a narcotic patch or a medication patch, you must wear gloves when you take off the old one and put on the new one, because you can get in contact with some of that medicine and it will go and it'll diffuse through your skin. So be mindful of that. You always need to wear gloves. And don't put the new patch on until you find the old patch and take it off. Okay, there are some nurses that forget, and then you go to put a patch on your patient for medication, and you look for a patch, and you see one on the arm, oh, here it is, you take it off. Then all of a sudden the gown slips down a little bit, and there's another patch, and you say to yourself, wait a second, what's going on here? And you uncover your patient, and they got patches all over themselves because the old ones weren't taken off. So please take off the old one before you put on the new one. And narcotic patches, they generally stay on for about 3 days, or about 72 hours. That's general, okay? So if you're taking off a regular patch, you can just fold it up, take your gloves off, have it in your gloves, and put it in the garbage. Where do you think you might dispose of a patch that has a narcotic in it?
With the, just like when you throw the syringes and.
Mm-hmm. And the sharps
Sharps.
container, right, unless your unit has a special place, but they don't go in regular garbage, okay? Because again, housekeeping or anybody that is taking care of your garbage disposal in your hospital, it can get in contact with them. Okay. Pharmacodynamics, this is just a term that describes the process by which the drugs interact and cause the hopefully intended effect on the body. Okay, pharmacokinetics is the study of the movement of drugs. You see kinetics is movement, how it's absorbed, distributed, metabolized, and then finally excreted. It is important to know about all drugs, how they are excreted in the body. Most of them are excreted by the kidneys, could be also metabolized by the liver, but they can also be excreted by the lungs in the form of sweat, saliva, or through the intestines. Okay? Some factors that affect drug action, think about this now with your patient. The age of the patient, okay? Developmental considerations. What am I giving a child versus what am I giving an adult? You will learn when you go to peds, most medications are weight-based, okay? But if you look at a small child or an adult, and they're of comparable age perhaps, but they have different weights, you're going to take that into consideration, okay? So even with the adult, a 90-pound elderly female versus a 350-pound quarterback professional football player are going to get different doses of medication. Does that make sense? Okay. The sex of the patient, sometimes that is a little bit influenced by the different medication. Genetic and cultural factors. This they still study. This is quite interesting that folks with different genes, because they come from a different country, a different part of Europe, a different part, in the world, their genetic makeup is a little bit different, and medications work differently on them as a result of that. What's a good example that we just experienced with regards to how genetic or cultural factors can influence a medication, how it affects you? Think about it.
Like if they're taking medication, some culturally they may take another thing and it can come together.
No, you're thinking of a reaction. That's good. I'll get to that. But we're all people, right? We're all humans. We're all adults. But we all have a different genetic makeup. So what happened to folks when they took the COVID vaccine? Did not everybody have varying reactions to that vaccine? That was a medication, right? Some people got nauseous, some people got headaches, some people mounted fevers, okay? And not everybody had the same symptoms. So that's just something for consideration. So when they create medication to eradicate different illnesses or different diseases, or they're making vaccines, okay, to save people, not every medication is going to work the same on everybody, okay? So just understand that. Psychological factors, what is that? I know you guys didn't take psych, but why would you think psychological factors might affect medication?
Well, it's like when you do experiments and they give some people just the placebo, and they think that it's gonna work or cause this, and end up, getting that.
Okay,
Yeah.
that's really good. That's really good. Does anybody remember what you call that? It's the placebo effect,
Yeah.
right? It's the placebo effect. Anything else that anybody could think of for psychological factors? Well, what if your patient is prescribed a medication, but maybe they have developmental disorder, processing disorder, mental disease? Are they going to be perhaps as compliant with the medication? Maybe not, because they may not understand. Right, or they may not understand. And also environment, okay? So, again, a little bit more with the developmental. During pregnancy, as most of us know, very, very, very few medications will be prescribed to the female, okay, because of the diffusion through the placental barrier. So anything greater than maybe a Tylenol, I think there would have to be a really good reason, and the patient would have to be monitored very carefully. Okay, and why do they not give drugs during pregnancy? Because they know there's a potential of it crossing the placental barrier. They can't study it, right?
Right.
Because the fetus is considered a protected, vulnerable class. So because they can't do the studies, they just won't give the medication, okay, unless it's really, really crucial. All right, I told you about children's doses are smaller. For the elderly patient, which is what we concentrate on in this course, they're also equally, if not more, sensitive. So they're going to be a little bit sensitive with their stomachs, right? Gastric motility, what they can digest. As you get older, the things that you could eat when you were younger, you can't eat them anymore. And it takes a little bit longer. Remember, everything is slower. The intestinal mobility is slower. So that means that maybe if the drug is excreted, via the intestines, it's going to be in the system a little bit longer. If they're sedentary, they're going to have a decreased blood flow, decreased circulation. If they have a failure to thrive and they don't have a good robust appetite, they're going to have decreased muscle mass, so they're gonna be very thin. So therefore, that puts them in a much more delicate category for medications. And then, of course, if they have any comorbidities. Remember I said liver and kidneys are the primary organs for metabolism of a medication. If they have any diseases with that, if somebody is on dialysis, if the kidneys are not working, if they have liver dysfunction, is that going to affect medication?
Yes.
Sure, absolutely, definitely. Okay, so we talked about weight, all right, talked about sex, again, with doses of medication, depending on the patient's body fat and how much fluids they have. Who has more body fat, females or males? Females, absolutely, okay. Okay, good. All right, so we talked about the liver, psychological factors, we talked about this, the environment, nutritional state, timing of the medication. This is important. Why do you think we give medications at certain times?
For example, the diuretic medications, if we give it late in the evening, it's gonna cause the patient to go more frequently to the bathroom and.
Yes, yes, absolutely.
It depends what reaction what we want for sleep or like for irritation, like before meal, after meal, like it's the aim of the medication target, like what we're targeting.
Perfect, perfect. So some medication, they want you to have a little bit of food
Right.
in your stomach. And there are some medications where, no, they want you to take it on an empty stomach, okay? So that's why we time it at certain points. Okay, so these definitions, you should be familiar with these because when you give medication as a nurse, you're going to want to know what the effect is, right? If you're giving a medication, you're expecting to see some type of effect. So if you have a patient in pain and you're giving medication to address the pain, you're going to go back and evaluate it because you want to see, was the medication effective? Did it make the patient feel better? So we're looking at the therapeutic effect. Okay, that's called the therapeutic effect. We want it to have the intended effect. So a pain medication, such as extra strength Tylenol for a patient's migraine, if it's therapeutic, the patient's migraine goes away and they feel better. Makes sense, right? An adverse effect, otherwise known as a side effect, that's bad, okay? We don't intend for that medication to behave in that fashion for somebody, okay? However, there are some side effects that are acceptable, okay? And that will be listed when you are looking up a certain drug, okay? But the adverse effect meaning bad, so say I give a patient an antibiotic and it's penicillin and the patient has an allergy to penicillin. Am I gonna have a therapeutic effect or an adverse effect?
Adverse.
Adverse, right? And the patient may have a really bad reaction. So that's not intended, okay? But if the patient has a therapeutic effect and their illness goes away, okay, that's therapeutic, that is what we want, okay? Iatrogenic disease, that's something that might happen if somebody is on a medication and we don't want it to happen. So it may cause a different type of illness. That's rare, okay, that's why the FDA studies all of these medications and they go through countless trials before they're released to the public. A drug allergy, you know, right? Tell me in your own words what a drug allergy is. What is it? Forget the definition that's up there. What is it?
Side effect.
Huh?
Side effect?
No, an allergy.
It's an unexpected reaction of the human body to substance, one of the substance or multiple substance on the drug. It can be in the form of rash or
Rash is very
like,
common.
or swell.
Right. So something is not agreeing with the body, okay? Your body is mounting some type of an immune response, okay? That is an allergy, okay? A drug allergy is when somebody is taking a medication and the body mounts an immune response against it, okay? And that immune response can be in the form of a rash, could be in the form of muscle aches, could be the throat closing up, it could be anaphylactic, it has varying degrees, okay?
It smells like your eye.
Yeah, your eyes can swell, your throat can swell, anything can swell, absolutely, absolutely. So again, it could be minor, it could also be very serious, it can occur immediately, or it can occur a little bit later on, could be days, could be hours. Okay, that's why we watch folks when they're first taking a course of medication. So some signs and symptoms, we talked about rash, really common, right? If somebody is on a different antibiotic and maybe 48 hours later they break out in a rash, you would suspect that it's the medication that they're on, okay? Hives is a little bit more extensive than a rash. Has anybody seen anybody with hives? They're like welts on the body, very, very itchy. Fever, okay, that's common. Diarrhea, nausea, and vomiting. Remember I said don't worry about the nausea, vomiting, and diarrhea because everybody can have that as a drug allergy. We're mainly looking for the ones that are more serious. Yeah. Because maybe I could take a course of antibiotics, but I'll be nauseous and I may have diarrhea because it's too much antibiotic for me. Maybe the dose is too high, maybe it's my stomach is too sensitive. So that would be adjusted. But that doesn't mean I'm not going to get the therapeutic effect from it, okay? All right, anaphylactic reaction. That's what I mentioned before. This is life-threatening. This is when your throat closes up, okay? You can't breathe. So the patient will go into respiratory distress. They'll have a severe bronchospasm. Their throat will tighten and close. And if they can't breathe, they'll go into cardiovascular collapse. So if your patient says to you, I can't take this medication, and you say, why? And they say, because my throat swells and it's hard for me to breathe. Oh my goodness, don't ever give them that medication, okay? Because some people will have progressive reactions. They'll start off with maybe, I don't know, a scratchy throat, maybe scratchy lips, swollen lips, and then the next time if they take that medication, their throat will start swelling and it'll become worse and worse, okay? So that's a medical emergency. Because why? What's compromised here? Their airway. Their airway. Very good. Okay. So if we see that, we call a rapid response right away. They bring the crash cart. They will give the patient IV epi and bronchodilators and also antihistamines and probably a course of steroids to bring that swelling down. A drug tolerance. Tolerance is something that you get acclimated to over a period of time. So a drug tolerance would mean that the body becomes acclimated or accustomed to that particular medication over a period of time. Larger doses of that medication must be administered to produce the same effect. So an example would be a patient maybe that has sickle cell disease, okay? That's a genetic disease. If you have it from childhood to adulthood, depending on what's going on, you can have episodes of sickle cell crisis, okay? That's when the cells become sickled. They cause a lot of pain. The patient doesn't oxygenate well. we give them usually opioids to control that pain. So anytime we start a medication, we always start low and titrate up, right? Because we don't know how the patient's gonna react. So the same would hold true for a narcotic. So maybe when the person was younger, we could give them maybe 5 milligrams of Percocet maybe, and that was enough. But as they get older, okay, the body develops a tolerance. They're gonna need more, so it would increase to 10, would increase to 15 over a period of time, okay? There are other diseases that are out there with the same thing. Parkinson's is one of them you'll learn about in 22. We kind of hold off on giving the big gun medication because patients get acclimated, accustomed, and they develop a tolerance. And with that particular disease, there's only so much drugs that we have available to treat it. And if the patient reaches the maximum, then we have nothing else to offer them, okay? So tolerance is something that can be influenced by your genes, okay? Can be influenced like that.
Drug
but-
addicts, that's the same thing, right?
Yeah, it's a tolerance, yeah. They need more and more, yeah, they need more and more. So depending on if somebody is addicted to
Thank you.
heroin, right, that's an injectable, what do we give them in place of that once they go through detox? Anybody know?
Methadone?
Methadone. Yeah, so are we doing them any good? Not really, we're just substituting one for another. Okay, but at least the methadone we can control. Alright, another definition is the cumulative effect. A cumulative effect is what? It's cumulative, it's like an exam, right? It's
stays on
everything
your
before
body.
plus what you have now. So with regards to a medication, it's when the body either can't metabolize a dose of a drug or it's maybe metabolizing it slowly, and then you give another dose of the medication. And then each new dose is going to increase the total amount of medication in the body before it's excreted. So with folks that have a slower metabolism, you have to be very mindful of that. So a good example is digoxin. Your patients get digoxin as a medication, right, as a cardiac drug. But every now and then you will see the provider will order a dig level, a digoxin level. So it's a blood sample, and they test the amount of digoxin that is in the body because some folks have a slower metabolism. And if it is at a toxic level or too high of a level, then once it's finally excreted, it's damaged the organ that is responsible for excreting it. So you have to be careful. So dig is one, there's certain antibiotics that are another. They draw levels to make sure that they're not too toxic. So that's the cumulative effect. Idiosyncratic effect, you don't have to memorize these definitions. I would prefer you just understand what they are. Idiosyncratic, I like that word. It's just a funny word. It means something is weird, okay? Something is just strange. It's idiosyncratic, right? It's weird. So it's a peculiar, abnormal, off the norm response to a drug. So it can be an over-response, an under-response, or completely different than what the therapeutic expected outcome should be. So a lot of times this has to do with somebody's genes, could be, a certain population of people for whatever the reason. And drug interactions, you know this because nurses have to be very well aware of this. If you mix 2 or more drugs, you can get an interaction. So the interaction can be higher, it can be potentiated, or it can be more adverse. So we say, if I give one drug, it produces a reaction. If I give a second drug, it produces a reaction. Hopefully therapeutic, not adverse. But some drugs, if you combine them, one drug either can cancel out the other, so the effect is not therapeutic, it's not effective, or it can be what we call potentiated and make it greater. So you will see that, for example, in the nursing home, they will give calcium, right, to patients, because it's good for them and it's a vitamin and, you know, increases their bone mass, and calcium is good. So they give that with vitamin D, okay, because those two drugs together enhances the effect of each other. So it's better for the patient. So that is what we call an interaction, but yes, it's synergistic, okay, and it's therapeutic. Okay, so that's a good thing. But you will see there are some medications that you won't give together because it brings down the therapeutic potential of that drug. Okay, so here, alcohol and barbiturates, that's an extreme example. So if you drink and take drugs, what happens?
That's it.
No, it's a synergistic effect. It enhances or builds. Oh yeah. Oh sure. You can die if you drink and you take drugs together at the same time. Yeah. You can overdose. Absolutely, you can overdose. So that's not good. Okay. All right, you know that somebody has to be legally trained and allowed to write an order in order for us to give it. We can't just give it. Okay, we can't do that. And we will talk about in lab, the order has to have many components of it. Okay, so we'll leave that until lab. All right, so types of orders, again, we're gonna go through this in lab, so I'm not gonna talk about it now. Okay, these are the parts of the order. We'll talk about this in lab. Rights of administration, we'll talk about in lab. Okay, those are all important 3 checks. We'll talk about that in lab. Common abbreviations. This is something you get used to as you get more familiar with medications. A lot of them are written out now because I guess maybe people are not really understanding what the abbreviations are, but as nurses, we should. So drops is GTT. Okay, if you see the abbreviation GTT, 2 GTT is 2 drops. Okay, so if you're giving an eye medication, you might see GTT. GR is grain, that's a form of measurement. G is gram, MCG is microgram. Are these familiar to you from 17?
Yeah.
Okay, so I don't need to go through all of these. All right. Routes we're going to talk about in lab. Okay, I'm going to go through all of that. Okay, let's see. We talked about transdermal patches to go on the skin and get absorbed that way. Can we give medication through the vaginal vault?
Yes.
Yes, we can. What's a medication that we can give?
Progesterone.
Progesterone, yeah. What else can we give? We can give quite a few, actually. We can give medication for a yeast infection, right? Right? Rectal, we can give medications through the rectum. The first we talked about was Tylenol. Under the tongue or sublingual, we'll cover that in lab. Okay, that patient does not swallow that, it dissolves, okay. Buccal or buccal, we'll talk about that in lab also, between the cheek and the gum. Think about the baseball players that chewing tobacco. Where do they park it when they're not spitting it out? Between the cheek and the gum, usually. rubbing it, a medication into a skin. Think about if somebody has chest pain and we're giving nitro paste, we're putting it on a little it's like a little cellophane sticky almost, and we put it on the skin so it's getting absorbed through the skin. And we talked about the eye drops, okay? You're placing the medication directly in the lid, okay, in contact with the mucous membrane of the eye. If somebody has a lot of wax in their ear, or they get a foreign body in their eye, we can flush or irrigate that organ with either plain warm water or with a medication in it. Okay, you've all seen the eye stations when you were in labs, right? Different labs in case you get something in your eye. And if somebody has a lot of wax in their ear, sometimes they will flush that out to dislodge that. Okay, patch to the skin we talked about. We'll talk about this in lab, inhalers, medication for inhaling. Okay, so how do we give these medications? As per the agency policy. So depending on where you work, you will have a set time. So for example, if you are giving a medication once a day, in this facility that time might be 10 a.m. Okay, in another facility it might be 9 a.m. Okay, it depends on where you are, but you generally have anywhere from a half hour all the way up to 2 hours to give a medication. So say you're late with a medication, okay, and you have to give it at 10, but maybe your patient was off the floor at 10. Patient didn't come back till 12. Can I still safely give the medication? Sure I can. Would I document why I'm giving it late? Yes, I would. Does
the next dose have to be 2 hours later, or?
Well, if it's, I'm just saying if it's within that time frame as designated by your policy, okay? So if your institution says, yeah, you can give it up to 2 hours, then I can give it at 12. If they say no, only a half hour, then I may have to call the provider. I might have to SBAR the provider if it's something that is important, because sometimes missing or omitting a dose is also bad, okay? Because then what happens is the body's bloodstream doesn't maintain that therapeutic level, okay? And it will drop. So if you miss a dose, it could be, what, not a therapeutic effect, but an adverse effect, correct? Yes? Think about it, okay. So you will learn, okay, because we're with you when you give medications, but even once you're a nurse and you're out practicing, if you are not sure what a medication is or what it does, ask, okay, ask. There's no harm in asking, and I would much rather you be on the safe side for your patient. If it's a new drug, hey, maybe your EMR, PDR doesn't have it listed. So what do you think you would do if you couldn't find it? Because it's pretty new. Who could you call? Yeah, that's right. You call the pharmacist, okay? The pharmacist, it's their responsibility to know what the drug is. Okay, so you ask them, you make a call and you ask them. You always want to check to make sure your patient is not allergic to medication, and it's usually written, but you know what? Maybe sometimes it's not. Maybe they forgot, maybe they wrote it somewhere else, but they didn't write it in the place that you usually look. Ask. If you are giving medication to a patient for the first time, ask them, are you allergic to any medication? Okay, are you allergic to any food? Can you eat shellfish? Okay, you want to make sure that what you're giving them is not going to produce an adverse reaction or worse, an anaphylactic reaction. The patient has the right to refuse a medication. They do, that's one of their right. We also can refuse to give a medication if we think the patient would have an adverse effect. So say the patient wrote, the provider wrote an order for a medication, I don't know, morphine sulfate, 2 milligrams, IV push, PRN, chest pain. Am I gonna give that medication?
No, I will push it gonna react very fast, it can hurt.
Yes, but what's missing from that order?
Can you say it again?
Morphine, 2 milligrams, IV push, PRN for chest pain.
The time, like how often?
The time. So I can refuse to give the medication because it's not written correctly. So we'll go over that in lab, okay? You need to know what the components are of a medication in order to legally and safely give it, okay? So what would I do? I would call the provider and I would say, hey, that order is incomplete. You know, what's the time frame that you wanted to give the morphine? And they would re-enter the order. Okay? And then I would look at it, and if it's okay, then I would give it. Okay. Now there's different supply systems for medication. You will see some of them. Sometimes, especially in the facilities where you are, they will keep a stock supply of medications that are common to the patient. So for example, you might see a big bottle of multivitamin tablets. You might see a big bottle of calcium or vitamin D. You might see a big bottle of maybe lactulose for constipated patients, okay, in the med card. In the hospitals, not so much. They don't usually keep large quantities of a medication. It's usually a unit dose system. So what is a unit dose system? It means that the pharmacist will package and send up to you, or it will be in your Pyxis system, just enough for that patient for a 24-hour period, or maybe a 12-hour period. It depends where you're working, okay? I've worked in facilities where the pharmacist comes up every 12 hours and takes the whole cassette out of the med cart and puts a new one in. So you better have given your meds before they come, otherwise they're taking them right back with them, okay? Other places have a big Omnicell or a Pyxis, which you may see in a hospital, and the nurse goes in, she puts all of her information in, and a drawer opens, and she's able to take out one packaged pill for the patient, which she'll scan before, she goes through all of her checks and gives it to the patient. So depending on where you are is how they provide the medication for you as the nurse to give it, okay? Again, some more common abbreviations. You went over this in 17, correct?
Yeah.
Okay. So you'll become familiar with it. A lot of times these abbreviations are written out, but not always. So it really behooves you to definitely know what they mean. Okay, what does QID mean? Anybody know? Huh? You should all be able to answer that question.
Every day.
It's not twice.
It's four.
It's 4 times. It's 4 times a day. Okay, this is stuff that you gotta kind of look at. Okay, you gotta look at and become familiar with. What's cap? Capsule. Very good. What's sup? Suppository. Short for suppository. What's HS? Hour of sleep. What time is that? What time is that?
Bedtime.
What time is that?
After 6.
You haven't seen an hour of sleep medication at your place? No? Well, it's usually 9 or 10 p.m., depending on the site. Yeah, look at the meds. Look how they write them. You'll start. Okay. Systems of measurement, metric, apothecary, or household. Household is like your standard teaspoon, tablespoon. Metric is pretty much basically what we go by, okay? The decimal system, you learn that in 17, okay? Apothecary, this is used very, very infrequently. Grains, minims, drams, it uses Roman numerals, so you gotta know your Roman numerals, okay? And of course, you know, eyeballing it is the least accurate, which is the household, okay? Okay, narcotics and controlled substances. Have you seen that in the facilities yet? Okay, they keep them double locked, okay? It's always double locked. So in the medication cart, the cart itself can be locked, and then there's a locked drawer within the cart. In a nurse's station at the hospital, the narcotics are usually kept in the medication room. So the room can be locked, the door, and then you have a double door for the narcotics. Why do you need so many locks? Well, it's a narcotic. I mean, you know, they could disappear and they could walk. But the nurses do a narcotic count
Yes.
at the beginning and the end of the shift. So if I give a Percodan at 10 o'clock in the morning, and God forbid I forget to sign for it, when they're doing the count at the end of the shift, they're gonna find a Percodan missing. So everything stops, nobody goes anywhere until we find out who gave a Percodan and what time, and then they get chastised for not following the process, which is signing for it in the narcotic book. Because when you give a narcotic, you're signing a narcotic book, and then you're also signing in the electronic medical record. So this is the federal government, okay? This is, what do you call that? The Drug and Alcohol Task Force, ATF, I think. Anyway, it's very serious stuff, okay? Very serious. If things are missing, if things are tampered with, there is a whole big investigation, and nothing is sacred. So you gotta be mindful of making sure that this process is followed, and it's followed exactly the way that the facility wants it followed, okay? If we need to discard a narcotic, say for example, I'm going to give 2 milligrams of morphine IV push, but the ampule in the narcotic box contains 4 milligrams, so I have to waste 2. There is a process for wasting the medication. You can't just put it in your pocket because you know your patient's gonna need the other 2 milligrams later on during the shift. Yeah, you can't do that. That's not good. You gotta waste it, which means you gotta get a colleague, and the 2 of you together, see, here's my morphine, I gave 2. You see there's 2 in the syringe, so come with me now and we're gonna waste it. So depending on the process, maybe they have a special bin for pills, maybe you can just squirt it down the sink. They kind of don't want you to do that anymore. But in other words, 2 people see it and 2 people sign it. So I can't go to my colleague and say, do me a favor here, I wasted this medication, just sign for me. No, because she can't do that. I don't care if she knows me for 30 years. She did not see me do it. Okay, so you don't sign if you're not witnessing it. Why? Because you don't know. You don't know. You could know the person for 30 years. Maybe something's changed in their life. You don't know. So you have to, it's nothing personal, it's the work. You have to be able to witness it and sign for it, okay? When you're administering medication, we'll talk about this in lab, there's a lot of checks that we need to do. Obviously, there's checks for the patient. You also need to check their band. Some places in the facility have a little picture of the patient on their band. I've seen that. I've also seen the little QC code.
You can scan it.
Yeah, you have to scan that in some facilities, right? So there's a system of checks and balances to make sure that you're not accidentally going to give the patient the wrong medication. You need to stay with the patient when they take the medication. Oh my God, I can't tell you how many times I've been in hospitals and we walk into a room and the student is assigned a patient, and what's sitting on the patient's table but a cup full of medications. And I'm like, and I just pick up the cup and I walk out and I find a nurse and I say, you know, I think you might have left this at the bedside. And sometimes they'll be like, oh, okay, because they know they're not supposed to do that. Or sometimes they'll just say, yeah, he takes it after breakfast. But you still can't leave it there. You can't, if the patient refuses it or wants it later, you take it back. You never leave medications at the bedside. Why? Yes, yes. Maybe a confused patient wanders in and says, ooh, maybe a little kid is running down the hall with the visitor and they run into the wrong room and they see, looks like candy in a cup to them and they take it, right? Happens all the time, okay? And of course, if they outright refuse their medication, that's why I open everything at the bedside. You just educate them and then you just document, okay? Because they do have the right to refuse, all right? And then of course, once they do ingest the medication or you administer it, whether it's IV or IV push, you document and you sign, okay? Never sign before giving a medication, okay? There are some facilities that are still on paper, and I have seen nurses, you know, doing their paperwork at 9 o'clock in the morning when they're having their coffee, and they're signing off all of their medications for the entire day. That is so bad. That is the epitome of sloppiness and really looking to lose your license, in my opinion. Because what happens if something happens to that nurse? If she gets sick and she goes home and somebody else goes to take care of her patients, they will see that everything has been signed off. And they don't know, did she give the medication? Did she just sign it and not give the medication? So you can't do stuff like that, okay? Very, very poor practice. All right, sometimes you need to check some vital signs. You know, maybe if you're giving a hypertension medicine, you want to check the blood pressure, apical radial pulse, if the provider writes that on the order. We always say keep your wrappers. I always open at the bedside, and as I open, I say, yeah, Mr. Jones, I have your Lipitor, and here it is, and it's, what is Lipitor for? If they know, if not, I'll do my little spiel and educate them on it, because sometimes the facility contracts with different vendors, and instead of making the aspirin round, now it's oblong, and your patient might ask you, what is this shaped pill, or what is this color pill? I always take a pink pill every morning. I don't see any pink pills. Where's my pink pill? That's all I know. So you will know if you open at the bedside and you have the wrapper, okay? And always please put each medication in a separate cup. If I have a patient that's on 5 medications in the morning, I'm gonna make 5 separate cups, okay? And I'm gonna give it to the patient individually. And if the patient says, no, that's okay, I'm used to swallowing them at once, I'm still gonna stay with them and watch them swallow it. But some people like to, and they can. And other people are very methodical. They'll look at each pill, especially if they don't know you. They look at everything and they will ask, what's this, what's this? And that's okay. So I kind of beat them to the punch and I say, here's your Lipitor, that's for your cholesterol. Then when they're done, I'm saying, here's your digoxin, that medication is for your heart. So I'm kind of preempting any questions that they might have. And then they're okay. As long as they see that you know what you're giving them, then they're confident in you, they'll leave you be, okay? Pain medications are a little bit different because if you're giving something for pain, you need to go back within a certain time frame and reassess. So if you're giving a pill for pain, whether it's Tylenol or a narcotic, Pills normally take about 20 to 30 minutes because they have to go through the stomach before it becomes systemic. And then you can go back within that time frame and reassess your patient. If you're giving a narcotic IV, if I'm giving morphine for chest pain and I'm giving that IV, I can assess the patient pretty much right away. I just gave you some morphine, I open up the fluids, let it go in. How you feeling? Are you feeling any better now? Okay, so you assess them because what you want is pain relief, okay? Most PO medications are absorbed in the stomach and then from the stomach, the small intestines. Common, as long as the patient can swallow, that's generally the most convenient way of giving a medication. But do know that it has a slower onset because of the digestion, okay? Can be more prolonged, but sometimes less potent. It depends on the metabolism of the patient, okay? If the patient has a normal metabolism or if they're older and it's slower. So we talked about the different forms of PO medications. You have your solids, okay? Some tablets are scored. Anybody know what scored means? There's a line down the middle and it's made that way for easy breaking it in half, okay? Enteric-coated, you know about that, okay? Never crush or chew an enteric-coated medication because you are defeating the purpose. Sustained release, if that comes in a capsule form, because it has SR, remember I said initials at the end, you would not open this capsule. The capsule is designed to dissolve gradually and release the medication inside gradually. So you wouldn't open that capsule, okay? We talked about liquids. Liquid medication, we pour it in a plastic cup because we have to be able to what? Measure the dose, right? And the cup is graduated with those medication levels. You pour from the opposite side of the label. Anybody know why we do that? Did they tell you that in 17? If my label is on this side, I'm gonna pour from this side.
So it doesn't drip and
Exactly. So it doesn't drip because sometimes medication, if it drips and it covers the label, it could stain it. And then maybe you can't look for something like an expiration date maybe, okay? So you always pour from the opposite side. And you wanna be at eye level so that you can measure the dose correctly. And it's measured on the bottom of the meniscus. So if you have a curve, right? If you have a curve like that, it's the bottom of the meniscus, okay? That's where you would measure your dose. And this is just the procedure which you're gonna do in lab. So I'm gonna skip right through that, okay? I'm gonna talk all about that. Skip. Okay. Signing for a medication is a legal document, okay? So whether you give it, whether the patient refuses, whether you miss a dose, even if you make a medication error, anything that has to do with teaching or teach back, signing for narcotics, everything is legal, okay? So that's why medication administration for a registered nurse is a very, very, very important task. And sometimes it can consume most of the nurse's day if they have patients that have a lot of medications to be given. So what's the most important thing when you give medications? We'll tell you in the lab, don't be interrupted. Focus on the task at hand. Only pour one patient's medications at a time. Don't say to yourself, I'm going down to room 202, so I'm just gonna give both my patients their medications, and I do, no. One at a time. I can't tell you how easy it is to make an unintentional medication error, okay? No one intends for a medication error to happen, but they happen. And they usually happen because the nurse is somehow distracted with something else. Either another nurse is calling them, a doctor wants to know something, a visitor is coming to the floor, something. So somebody comes over to you when you're preparing your meds and says, oh, look at these pictures I just uploaded to Snapchat, blah, 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 whatever. No, you have no time for that now, okay? You have to do the job at hand because your patients depend on you. And of course, never leave medications at the bedside. Okay, these are the variables we talked about earlier. Okay, and here are some nursing diagnoses that relate to medication administration. So if you have a patient that you're giving meds to, and maybe, I don't know, they're anxious, they have a knowledge deficit. Some of these medication, these nursing priority problems or diagnoses might be very applicable to your patient, okay? Knowledge deficit is a big one, okay, because most patients are not very knowledgeable about their medications. They take it because they were told to take it. Their doctor prescribed it and they take it. Some patients are exceptionally knowledgeable. I always compliment the ones that know a lot about their medications because, you know, they're taking an interest, and I think that that's important. I think all people need to be mindful of the care that they're receiving. So whether it's a treatment, whether it's an intervention, whether it's a medication, anything a provider does for a patient, I believe that patient should be very well aware of what it is and why they're being prescribed that particular activity or medication. So I will always teach them. And if they said, oh, I've been taking digoxin for 20 years, I know all about that medication. I'm like, oh, great, you just made my job easier, so tell me about digoxin, and I'll get a teach back from them, okay? And if they are aware and they understand, then I can move on to something that they don't know, okay? But I've done my job, and I can document in my notes that I educated the patient and did a teach back on digoxin, and the patient was very knowledgeable. Done, finished. You move on to the next thing, okay? Does that make sense? Body image is a big deal when it comes to medication. You'll learn more about that in 22, especially with chemotherapy, and think about perhaps surgery to remove tumors that can cause body image disruption for the patient, and that's a real thing. Body image also depends on the culture, okay, also depends on the age of the patient. You know, when we get a little bit older, we accept that the body isn't society perfect, but when you're young, everything you see on social media, you want to emulate that. You think that is the perfection. So body image is a big deal. It's a big deal. Okay. Any questions on this? Fairly self-explanatory. What do you think? All right. Well, think about it. You can ask me. All right. Let's move on. Do you want 5 minutes before I move on to the next? Because I got to get through these. Or you want to wait?